Next, I would like to invite Dr. Nishanth, who will be speaking on Back to the Surface, Perfecting the Art of PRK.
Thank you. I'd like to thank Pooja, Ritika, and AIOS for giving this opportunity. So yes, no financial interest, but I'll be talking about the only machine I have, which is the Schwind, unlike Pooja or Rushad having an options of classic machines. So why are we coming back to the surface is the question which many people ask. Yes, we all know that there used to be haze, which was used to be one of the main complications, and regression and treating of high diopters. But over the years, with this technology of the trans-PRK, I think there's a lot which have changed due to my personal experiences as well. We know that PRK, you have to take off the epithelium either manually or with alcohol, all with a PTK mode, and then you do a PRK. But what different happens in the trans PRK is what I am going to talk about, where the ablation of the refractive component is actually done first even before the epithelial surface is removed. So the stromal bed is much more smoother and the epithelial resurface modeling is much more healthier and better. Usually for a PRK we have around 5 steps, but in the trans PRK there is actually just a single excimer step which removes both the epithelium and the refractive correction. So this is what a Schwind page will look like for the ablation profile, and I will be talking about it in detail. So the main advantages is it is one step. So our center is something which is open for other doctors. So I have trained retina surgeons, glaucoma surgeons, and who not for doing this trans PRK, and they are very happy about it. You can also combine it with the abrasion free profile or the corneal wavefront guided and the ocular wavefront guided for higher order aberrations and retreatments as well. There is no alcohol required and there's no interruption between the two lasers, which is the PTK and PRK, and it's a much faster healing process. The one of the advantage is the eye tracker. Normally you have the first, second, third, fourth dimension. The Schwind 1050 actually has the sixth dimension, that is the Z axis as well. We have some obese patients who actually you must have seen while they are just normally breathing, the eye tends to move forward and backward, which is also taken care by the sixth dimension. So how does it work? So there is based on literature that more than 70% of the population's epithelial thickness is around 55 in the center, and as it goes to the periphery it comes to around 65 at the 8 mm zone. So that is what the profile which is kept for the Schwind as well. And the epithelial removal is actually refractive neutral. So the calculation is based on two different ablation values per pulse. One is for the epithelium, which the laser ablates more tissue per pulse, and the other is it for the stroma. So this technology is what changed lots of machines actually to bring back the trans PRK. So we had the PRK, the PTK PRK, but the trans PRK is something which came back to a lot of machines which they have started. What is this smart pulse technology? It's a pulse technology to enhance usually a short-term outcome. They work on the fullerene model. So I'm sure that during our physics days we had these atoms and bonds. So that is the fullerene model which actually inculcates with the three-dimensional module of the cornea, and it gives really a wow effect. So what all does it do? It actually reduces the roughness of the stroma. It improves the smoothing of the residual bed, and without compromising the stability or long-term outcomes. That is, it also includes the aberration. So you can see that the picture to my left, which is actually a horizontal grid-wise, which is actually an ablation profile described as 3D volume. So it is flat. So the plane is corneal, surface is flat. But vis-a-vis, when you have the fullerene model, it works with the x, y, z coordinates based on the curved corneal surface with equidistant intersection. So that is the advantage where the smart pulse technology gets its wow effect. So it helps in position of individual pulse more closely, results in higher resolution due to the use of 3D model, and it is based on sophisticated spot geometric analysis and the state-of-the-art test and measurement equipment close to the technological limits. So this is a microscopy which actually in the left you can see that it is without the smart pulse technology, and in the right with 1000x you can see that how smooth the stroma is. So this is the profile PRK with the trans PRK in a myopic profile, you can see that it blends over it as you go to the transition zone. So it's a one-step procedure with no touch, no chemical, and no blade technique as well. So how is the calculation which is done in this machine? So you have the three profiles, as I said, the abrasion free, the ocular wavefront guided, and the corneal wavefront guided. So this you can the ocular wavefront guided, usually I do it for retreatment or people whose vision doesn't improve to 6/6, where they have some amount of aberration which is causing a drop in vision. The epithelial thickness is taken for the center and the peripheral. The subjective refraction is entered here. And here we have all the modes of trans PRK, PRK, LASIK, and even relift for procedures as well. So PRK is done only if you are doing the epithelial removal manually or with the use of alcohol. So these are two different things where you have the abrasion and the corneal wavefront guided. You can see that the lower right is where you have it with the corneal wavefront guided. You can see that the ablation which is done is much more than the one which we have done it with the aberration free profile. And in terms of the aberration free profile, you have a lower tissue ablation where the depth is minimized. Even in the corneal wavefront guided treatment, there are lots of aberrations which you can actually manually decide which you want to delete and which you want to keep it. Some people with high astigmatism might have more coma, more trefoil. So you have the manager which actually takes the Zernike polynomials, and then you can decide which order aberrations you want to keep to increase the residual depth. So this is a small video just to show how touchless this procedure is. Actually, so you can see that the debris removal comes, and once you actually make a focus on the cornea, so that's why actually I counsel the patient that it is a bladeless, touchless, painless procedure. So this is how you keep your hand. So there's nothing to touch. So if you can hear the machine, I'm not sure about the sound. It is the ablation of the power which happens first. You can see that it takes approximately for 4 or 5 diopters, it takes approximately, and then the epithelium has started. I'm not sure if the sound is visible. So there is no stopping, there is no focusing. Just once I did a refocus because the patient moved a bit, the pupil tracking takes care of it, and then there is nothing else. So this is all I do for the whole procedure of trans PRK. So this is one of the best way to actually tell the patient that it is a touchless procedure. The machine takes care of it all. So there's also a study by Rochetti et al. Where they've told about the corneal remodeling, which was discussed about in the previous video. So what happens when you actually have an increase or decrease in the epithelial mapping? As I told you, the normal is 53, but it's always better to have an anterior segment OCT to decide the epithelial thickness, because if it is around the range of 55, yes, it is good, but if it is thinner, there is more amount of ablation which happens to the stroma, and if it is thicker, there is less amount. So usually I keep a standard of 1.5 diopters. Any diopter more than that is what I do for trans PRK. Anything less than that, I either do the manual or the alcohol removal. It is always safer because even if you have the epithelial thickness for lower powers less than 1.5, I prefer PRK as a better choice. So how it works? If the epithelium is thicker, you can see that for myopia, only some extra tissue is removed, and for hyperopia also there will be some extra tissue which is removed. If it is thicker than the trans PRK profile, you can also play with the optic zone. So just make sure that you have a smaller optic zone, and in hyperopia to a wrong curve correction. So that also, when the patient is having more cylinder, I increase the optic zone. And one more advantage is retreatment. So previous ablation of the regrowth of the epithelium is different in virgin eyes. So for them, I do a corneal wavefront guided treatment, and the highest ablation will get the highest amount of regrowth epithelial cells. So trans PRK has its benefits in retreatment, even post keratoplasty surgeries, residual powers, and even refractive surprises post cataract surgery. This is just the tabular column which I have told, which is the best perfect module, which says that if the epithelium is around the base of 55 and 65 in the periphery. So the zone selection is also based accordingly. You can see that below 1 diopter, no trans PRK. Around 1 to 2, we keep the optic zone of 6.3, and 2 to 3 around 6.5, and 3 mm above, it is always better to keep the higher optic zone. So what is the take-home message? It's a one-step treatment, no touch technique, fast epithelial healing, no flap, no incision. Yes, you can also add the word saying that it's a lenticuleless procedure, and for people who don't have the lenticule machine, and it's perfect for myopic treatments. Thank you.
Thank you. Thank you, Nishanth. So I had a question regarding your hyperopic treatments. Do you enlarge the zone of the PTK or what exactly
Yes,
do you keep
for
for that?
hyperopic, I always keep them at 7 if we get the residual stromal thickness. If you still have it, I keep it at 7.
And generally, what aberration do you most of the time remove?
Aberration-free treatment is
Okay.
what I do most of the time.
Hi. So do you have a protocol for depth minimization, or do you do it for all patients?
Which one?
Depth
Ritika?
minimization.
No. So,
So you do it
yes.
particularly more than 80 microns of ablation, or do you have a cutoff for that?
No, so I think I base it only on the stromal residual thickness. So
Thickness.
if it is there, we are doing a corneal wavefront guided treatment, and if I have a thickness above 350, I don't do any depth minimization.
And your OW treatments, do you do it for more SA or
I have never done.
you have never
I've
done
never done. So I think
OW?
you do it for what OW?
So OW treatments are the ocular wavefront
Mm.
treatments. So it's done by whenever we are doing an aberrometry. If the aberrations are high, which are the lenticular aberrations, which are the internal aberrations, if they are high, then there's no point to treat the cornea
Cornea.
as a whole with the -2. If the -2 diopter is 1.5 contributing by the lenticule, then we should not treat that. We should only treat the corneal
Yeah.
depth.
Thank you.